Hello, everybody. I'm Anna Plotkin. I'm the president of the Ontario Association of Pathologists, and this is our last day of Ontario Association of Pathologists annual general meeting. Just to remind everybody that you are getting evaluations every day after the meeting. Please fill out, and especially it's important if you provide us with your suggestions. We're looking carefully after each conference and would like to improve in the future. And please remember to pay your dues for 2019 to 2020. That would be highly appreciated. And today I have a great pleasure to introduce a big friend of Ontario Association of Pathologists, Dr. Robert Riddell, who doesn't need any introduction, and he's very humble, and he told me not to introduce him, but nevertheless, he graduated from the University of London in the UK, St. Bartholomew's Hospital a long time ago, and trained in GI pathology at St. Mark's and St. Bartholomew Hospital in London. He moved to University of Chicago for what should have been 2 years, but stayed for 10 before moving to McMaster University in Hamilton, Ontario, where problem-based learning began. He moved to Mount Sinai Hospital in Toronto in 2001 and has been there since. He enjoys teaching and discussing GI pathology with anyone that he will listen, and has been part of GI pathology fellowship training program for over 30 plus years. He has around 300 publications and a few books which are largely in gastrointestinal pathology, primarily inflammatory diseases, dysplasia and carcinoma. But I have to say, on my personal note, he has absolutely amazing sense of humor. And I love talking to Dr. Riddell. He's absolutely amazing person. And thank you very much for agreeing to participate in our meeting. And we're all thrilled to your talk. The floor is yours, Dr. Riddell.
Thanks very much indeed, Anna, and thank you ever so much for the invitation. Well, welcome everybody. I'm sorry I can't see you, or I guess I have to start getting used to that. So we only have an hour or so to make the best use of this time. I've selected a few very practical topics, and these are all subjects that we see in our consult service. So we know that there are things that do cause people problems, or they have a degree of discomfort. And as a result of that, I have to thank you all for sending the cases in, or we wouldn't have a conference today. So I'm going to make this very, very practical. Some of these slides just have one major point, and I hope they'll appeal to a whole range of people over there, whatever your level is in GI pathology. It's going to be primarily an H&E based session. Because of the format, no learned discussions or discussions about molecular and all those things that people are wont to do. So what I'm going to do is, in looking at the areas that people have problems with, so large bowel polyps come up all the time, and particularly serrated polyps, and what's going on here and what's the implications of that. So I'm going to start off by looking at some large bowel polyps, particularly the serrated ones and the variants. Then I'm going to look at inflammatory disorders of the upper and lower GI tract, and particularly looking at the non-Helicobacter inflammatory diseases in the stomach that do cause problems. So having said that, I'm just going to put this to one side. So the first case I hope you can see on the screen. Now this is pretty basic stuff. And I'm going to start off, there's a polyp in this slide, and you can see there are 3 pieces of tissue. And the one on the top, even at long range, looks different, but it doesn't look hugely different. And if I just put this one up with the next one, you can see the normal large bowel is down at the bottom of the screen with the usual test tube-like crypts. And the one at the top is almost identical, except the crypts are larger, wider, so if I just flip up, so normal crypts, and I'm just going to pop down to the other one, just much, much larger crypts. Now, there's nothing serrated about this, but this is in fact the goblet cell variant of a hyperplastic polyp. And it's one of those things that some people have problems with, and you can understand why, because they're not serrated, they're not microvesicular. The number of goblet cells can be a lot or relatively little. And when there are few, you sit there and wondering whether you might be dealing with a very, very low grade adenoma. So these can be problems. And I have to say, whenever I get one of these, if it's easy, I get a couple of levels just to make sure I'm not dealing with an adenoma. So this is very supposedly straightforward. So this is the goblet cell variant of a hyperplastic polyp. And if I go back to low power, the easy way of doing it is if you've got some normal mucosa. My program's deciding to play around. Okay, so it's a crypt size thing. So if you see the size of the crypts of normal crypts and compare them with these, the two are very different. And I'm not sure why my program's playing around, but it is. Okay, while this is just writing itself, in fact, I might just close this down and open it up again. I don't know how long it's going to take. Okay, so this is the one that I just opened up. And again, this is just the compare the normal size crypts with the much larger crypts of the hyperplastic polyp. So that's the first one. Now, the second problem that we see in some of these Okay, so here's another, and you can see this one looks like a fairly typical sessile serrated polyp. You can see the irregular shaped crypts, the boots, and so on. And I'm not going to talk about sessile serrated polyps, but if we look in the other section here, there's something really weird going on in this half of the polyp. And you can see there's a spindly type proliferation, and you can see here that the fibers of this thing tend to run transversely across the screen. And you can see also that it tends to compress the lamina propria. So if I go down, you can see this lesion runs from about here. In some areas, it occupies the whole screen. And notice these transverse running fibers. So this lesion, you can call it either a perineurioma or a benign fibroblastic polyp, and they can occur by themselves or they can occur in association with hyperplastic polyps or particularly sessile serrated adenomas. The combination is very well described, and interestingly, they both have the same BRAF mutation, but there aren't too many BRAF mutations either. So just note that this combination does occur when there's no sessile serrated lesion. They just form primarily transverse running fibers, and they can be mucosal or submucosal or both. And sometimes they can wrap themselves around glands and give you really weird examples. So you can see in the left-hand panel here, there's what looks like a regular old hyperplastic polyp. But in the middle here, there's this strange thing. It still looks largely like a hyperplastic polyp, although some of the glands are getting quite complex. But if you look what's going on in the background, again, these peculiar transverse running fibers, again, very typical of a benign fibroblastic polyp or perineurioma. Now, the only real differential diagnosis of this lesion is a Schwann cell hamartoma. So the only special stain you really need is an S100 just to make sure you're not dealing with a neural tumor. And in fact, the only one of those that matters is actually a ganglioneuroma, just because some of those are syndromatic. So in these, all I usually do is just have a squint around and make sure there are no ganglion cells in there that would tip me off straight away. The problem with perineuriomas is that they don't really stain for anything very much at all. And about the one thing that they will stain for sometimes and hugely weakly is EMA. So this is an EMA stain. I think you can see in these spindly fibers, there's just a very light blush of immunostain. If you really
Bob,
want,
sorry to interrupt you. Can
yeah.
you please expand your screen?
Oh, I'm sorry, I didn't expand the screen. You're right. Apologies. Yep. Thank you for reminding me. Um, so you can see these fibers that are just taking up a hint. If you have stains like Claudin 1, they'll light these things up, but you really don't need it. So that the algorithm just goes with these. Is there goblet cells, sorry, are there ganglion cells in there that might tip you off that this is a ganglioneuroma? And if not, do an S100 just to make sure it's not a Schwann cell hamartoma, but otherwise, benign fibroblastic polyps, also known as perineuriomas, are relatively common. I'm guessing that probably most of you see them. They tend to come up in regular old surgical pathology. They don't usually mix up with crypts quite like this. They're usually overtly mucosal, like the first example I showed, or they're submucosal, or they run into both. Okay, so having said that, let me just flip open my next case. Okay, so here you have multiple fragments of another serrated lesion, and clearly serrated at the upper ends of the crypts here. You can see some little bits of irregularities, so it looks like an SSA. Just as a little sidebar, when I'm looking at these things, I never look at the site. I just do it on morphology. Basically, these lesions can occur anywhere around the colon. Hyperplastic polyps can occur in the cecum or ascending colon. These lesions can occur in the rectum. So I just try and ignore the site, because every time you see right colon, you're really geared in. You're going to make it an SSA, come hell or high water. When I'm talking SSAs and SSPs, some of you may be into SSLs, sessile serrated lesions. We've not adopted that. You're free to use whatever terminology you like, as long as your clinician understands what it means. Interestingly, it turns out that when the WHO were having their little powwow, this discussion never came up, and it only actually appeared in the book. So the people that were discussing these lesions were a tiny bit surprised, particularly as throughout the book it tells you that we're not to use these lesions. But it's been a fairly hard job getting our clinicians to accept sessile serrated adenomas, if you use that term, without dysplasia. And we have no great plans on changing, but it's all about communication. If you want to do that, that's fine. Now, this polyp has two lesions on it that can cause problems. The first one is, you can see the mucosa here, and there's an island of cells underneath. And you can see them here, and they're still serrated. And one of the things about all serrated lesions, doesn't matter whether they're hyperplastic polyps, sessile serrated adenomas, polyps, whatever you want to call them, is they have this propensity for having misplaced glands in the submucosa. And as you can see, some of these can run off into the fat. So it's not as if they're tangential. They're not surrounded by a muscularis mucosae, but they just do this. Now this starts getting a bit problematic when these become dysplastic and you've got dysplastic glands running into fat, because then you start wondering, am I really dealing with a very low grade infiltrating adenocarcinoma? Now, the good news about that is that unless they have high grade, they're either high grade or they have poorly differentiated components or budding or LVI, they don't go anywhere. So they're effectively benign lesions. I'm just going to back off on this one, just a fraction, because you can see there's actually a much larger area of misplaced glands on the other side of this lesion. And interestingly, if you look at the muscularis mucosae, there's not much in the way of muscularis mucosae. You can see it up at the top here, but once this seems to stop, that's where the glands start going down into the submucosa. So there seems to be something about losing the muscularis mucosae. I've got a thing here saying, but you can see these going down, and just accept that serrated lesions of any sort can do this peculiar trick that they have of going into the submucosa, and it's of absolutely no consequence at all. Now I'm going to move into this next part of the polyp here because again, it's the same serrated polyp, but this part you can see over here is clearly becoming dysplastic or has become dysplastic. So I think by anybody's criterion, it's an easy call. Note that very typical nuclear characteristic, they're sort of open. They're not the deep hyperchromatic nuclei that you see in typical adenomas. And you can often see little nucleoli in there as well. So this is an area of dysplasia associated with a sessile serrated polyp. And dysplasia comes in a variety of forms. This one is clearly very localized. Sometimes it could involve much and sometimes the entirety of the lesion. Now, there's a lot played about these things losing MLH1 or not, and you can do that just for fun. And this one, I've done it just for fun, so you can see. And you can see the little area that we were looking at is at the top. I'm just going to show you, so here's the control crypts over here, and you can see the nuclei staining up. And if I squeeze down to this other lesion, several things. You can see the background nuclei are staining, but the serrated lesion is not staining, so it's MLH1 deficient. And neither is it the dysplastic or adenomatous component. So if this went on to a carcinoma, this would presumably be a microsatellite unstable carcinoma. Now, the crazy thing about these lesions is when they become dysplastic, sometimes the dysplasia is not microsatellite unstable, it just stains normally. So these sessile serrated lesions with dysplasia can be either a microsatellite stable or microsatellite unstable, which means they can give rise to either type of carcinoma. Okay, and that's about all I had to say for that. So those are all variations on a theme of serrated lesions. Okay, so 4, 5, 4. So the last one I want to show you in this little series, again, several pieces of tissue. This one's a little bit interesting because you can see an obvious little polyp. It looks like an adenoma, but you can see at long range that it's serrated. Not only is it serrated, you can see it has these ectopic crypts running down the side. And if I go up to higher power, you can see that it has this typical serrated pattern of dysplasia with these fairly open nuclei. Here, I hope you can see the small nucleoli. And this is a fairly typical small traditional serrated adenoma. Now, one of the crazy things about TSA, if I go down to the side of this lesion, and just open this up, you can see there's what looks like a little hyperplastic polyp at the edge. And it's really quite common to have TSAs associated with either hyperplastic polyps or sessile serrated lesions with or without dysplasia. And a modest number of the consults we get are because of these complex lesions. And the question is, what do we call it? And the options are, you can, first of all, pathology is what do you see? So you describe what's there and then how you interpret it. So in this one, we have a traditional serrated adenoma with an adjacent hyperplastic polyp. And so that's what you see, and those are both fragments, the elements that are there. And then the obvious question is, does the TSA arise from hyperplastic polyps? Well, that's a strange thing, but this one seems to, all you can say is that there is an association here between those two, and you can speculate whether that there is an association. But it's really quite surprising how many TSAs have an associated SSA or hyperplastic polyp, or sometimes both. So combined serrated lesions are not at all uncommon. It's just a matter of being aware that you can get these crazy mixtures. By all means, you can, if the one that matters here is the TSA, and the hyperplastic polyp sort of doesn't matter because the treatment is predicated on what's going on in the major lesion. The interesting thing about TSAs is the vast majority of them are left-sided, descending colon, sigmoid colon, but once every now and again they flip across to the right side and they don't read the books. And I think this one was in fact a cecal lesion, but it really doesn't matter, they are what they are. Now, I just want to pop up one little chart here. I hope you can see this. This is the CCO recommendations on polyp follow-up. And what I want to get in here is hyperplastic polyps, 10 years. This is as a result of their FIT screening program. Low-risk adenomas, that's 1 or 2 with low-grade dysplasia, come back in 5 years. High-risk adenomas are 3+ adenomas or greater than 1 centimeter or a villus component. And what's the fourth one? Forgotten the fourth one. High-grade dysplasia. Okay, and you can see that these all come back around 3 years. Greater than 10 adenomas is 1 year, but these are all the sessile serrated lesions. So the little ones come back in 5 years. Everything that's dysplastic comes back in 3 years, but notice if they're removed piecemeal, you really have to get them back pretty quickly to make sure that they really have been completely excised. And certainly the vast majority of serrated lesions that we see are usually removed piecemeal, and most of them do come back. There was a paper from Boston a few years ago, and they asked the question, how easy is it to completely remove some of these sessile serrated polyps? So the endoscopist went in and the question was, can you find them? And they found them. And then can you completely excise them? Because somebody else was going to go in right after them to see if they had completely excised them. And even knowing that somebody else was going to completely go in right after them to see if they'd done a good job, in approximately 1/3 of these polyps, there was residual SSA at the edge, so they're not easy to remove. And I suspect, like us, the vast majority of these lesions you get are taken out piecemeal. Okay, let me just close that up and get back to this one. Okay, so those are the serrated lesions. I'm just going to remove all these images to try and stop my program from crashing and just open up the next little subgroup. Okay. So this is the last one in this series. So this one you can see is a larger polyp that's been bisected. Now, if I go up onto higher power there's several things catch your eye right away. The first thing is that if you run along the surface here, you can see that there are some serrations going on. A lot of this polyp is serrated, but the serratedness tends to be superficial. Down at the bases of the crypts look pretty well normal, and the sides have this fairly typical serrated dysplasia. So we know we're dealing with a serrated lesion. We know it has low-grade dysplasia. If I back right off and you start looking, so the question is this just a dysplastic sessile serrated polyp? And okay, this looks as if it might be a boot here. And the weird thing is that the base of this crypt looks absolutely normal, as does the base of this crypt. So tough to know if that's a boot or not. This one almost seems to have a junction, as if the dysplastic epithelium is taking over the rest of it. So this does not look like a typical SSA, although if you wanted to call it a sessile serrated adenoma with low-grade dysplasia, that's absolutely fine. It will get you into the same follow-up as everything else. When you get to the top, you're losing goblet cells. It doesn't have ectopic crypts, so you can't really put it into a TSA category. So the problem with this thing is it doesn't really fit into anything. The superficial eosinophilic appearance is much more like a TSA. It still hasn't quite lost all its goblet cells, but it doesn't have the ectopic crypts, and it doesn't really have the architectural distortion of an SSA either. So really the problem with this one is it doesn't fit. So it's really an unclassified serrated polyp with low-grade dysplasia, and that's quite acceptable. If you wanted to call it an SSA with low-grade dysplasia, that's fine. If you really thought this was a TSA to be and wanted to call it an early TSA, absolutely fine, because it doesn't make that much difference because they're both managed the same. Because this doesn't fit, I actually popped this into the sessile serrated polyp or adenoma, unclassified with low-grade dysplasia. But the problem is some of these polyps just don't read the books, they don't read the classifications, and they do what they want. And if it doesn't fit, it doesn't fit. If you want to make it fit, that's fine too. So this one again, this one is probably just an unclassified, probably unclassifiable lesion. And it doesn't matter where you look, there's nothing really here that really looks like a typical TSA. The architecture here is pretty good. They look like normal crypts, except they're serrated at the top and dysplastic in the middle. Okay, I'm just, yeah, okay, so just trying to keep an eye on my chat thing there. Okay, so let's open the next one. Okay, so now we move into the next category of polyps that cause problems, and these are polyps with things going on in the submucosa. So this one has two parts, little stalk here, clearly an adenoma. Whether you call this tubulovillus or tubular is up to you. One of the things that I talked about, villus is, okay, so the four categories of high grade, so villus, high grade dysplasia, what greater than 1 centimeter or 3 or more adenomas put you into that high grade category. The problem is that the inter-observer variability with both high grade dysplasia and villousness is absolutely terrible. And in practice, almost all of these polyps are over 1 centimeter. So increasingly, people are gently dropping whether it's villus or not, because in all fairness, when you this polyp, as you can see, is probably about 1.4, 1.5 centimeters. And the number of polyps with high-grade dysplasia that are less than 1 centimeter are really pretty small. And the number that are villus are also pretty small. So this is, I think these are gradually going out of vogue. Now this one is really weird because this is not typical misplaced epithelium. In fact, it's not really clear whether it's in the submucosa, but it probably is. There's a bit of muscularis mucosae here. And this has lamina propria in there. And it's one of these things that just doesn't fit. Little bits of lamina propria here, no desmoplasia, no hemosiderin, no blood. Just seems to be a funny bit of few glands and probably falling off into the submucosa. Well, we're sort of saved because in the adenoma, and here there's something clearly going on in the middle. And you can see the pattern here is architecturally that of an invasive adenocarcinoma. When you start getting these crazy crypts, adenomas do not do this. And it's running down into the submucosa. There's some desmoplasia here. So this looks like an early invasive adenocarcinoma arising in a tubular adenoma. Now, what's our job with these? Our job on the whole is to kin to trouble, and our surgical colleagues, because you say you've got, this is a polyp and it's got cancer, and the knee jerk is you need a resection. But the fact of the matter is that for polyps to have a risk of nodal metastases, do need to have high risk features present. And the high risk features are high grade budding, that is buds with more than 5 buds per times 20 hyper invasion. So this one has none of those, although if I flip up, there are some areas here. Here you go, where you might say, is this a couple of buds? Buds are actually quite difficult, particularly when there's an inflammatory component. But if you look, this is actually part of what looks like a larger gland. And if you can see any sort of gland, that disqualifies it from being a bud. But you do need 5 buds or more in a high power field. So this does not have 5 or more buds. For what it's worth, I always run a cytokeratin on these just to make sure there's not an area in here where I need to go back to the H&E and look a bit more carefully for buds, but there are no, that's not present. I often run just an elastic stain just to make sure these aren't stuck in a vein. And there's no poorly differentiated component. So when those three factors are missing, the chances of this metastasizing is less than 1%. It's probably around 0.6%. And that's probably lower than any sort of directive on that. So we say there are no high risk features, and all you need to do with this patient is just follow them up. If you get adenoma down at the margin, and this one looks as if there may be, now the cautery maker may have taken care of that, but nevertheless, you may still have to go back and just make sure that local excision is complete. But bear in mind that at age 70, a sigmoid colectomy, which many of these is where many of these occur, actually has a 30-day operative mortality in the region of 5%. That might surprise you, but patients go home and they have pulmonary emboli and things like that, and or their anastomotic lines break down and they have coronaries. It's a surprisingly high figure, but those figures came out of a teaching center in Calgary only a few years ago, so I have no reason to think they're not true, and they actually comply with other centers as well. Now, if you have any of those other three features, so more than 5 buds, a clear LVI, or a high-grade component, for any one of those, the risk of lymph node metastases goes up to about 20%. And it depends which figure we use, but 20% is about the maximum. And if any 2 of them are present, that's around 30%. Now, that also means if you do it backwards, that if you only have one of those present, there's an 80% chance of you finding nothing in a resection. So you can actually justify doing nothing. This is not an all or nothing thing. You can always start off with the baseline CEA. You can always image the local nodes and keep an eye on those. There are a variety of different things you can do to ensure that these patients don't come unstuck if you're really worried about it. But our job is to keep them out of trouble, and there are probably a lot of unnecessary resections done on the grounds of you've got cancer, therefore you need a resection. So that's just not true. And with carcinomas like this, if you say the risk of lymph node metastases is less than 1%, so no further therapy is required for that. Well, okay, there are some patients that are totally cancerophobic and will absolutely insist on having a resection. And with luck, the surgeon will reassure them and say, it's really not necessary, and won't do it. But, the thing is, all of these you end up managing on an individual basis. Okay, let's see what the next one is. Okay. Okay, so this is another little adenoma, and this is just a little variant that one sees from time to time, but you just need to be aware of it. So what you can see here, here's an adenoma. Here's one of these typical lymphoid aggregates that tends to sit on the muscularis mucosae, and this can be quite hard. They destroy the muscularis mucosae, and what you can see is that this adenoma is running off into this lymphoglandular complex. Okay, now this is not invasion. Adenomas do this, and they do get into the submucosa, and it is a source of concern. But while this is still an adenoma, it's not an issue. These never metastasize. And you can see, even if you wanted to call it a carcinoma, it's at best only minimally invasive. So you just have to be aware that you can get misplaced adenomatous tissue in the same way that you can get misplaced normal colonic mucosa in these lymphoglandular complexes. Now, this one, so that's as fine as far as this piece goes. Now, this one is a bit weird because if you start looking around, you can see there are other little islands in here. Okay, one there, one here forming a gland, one here forming a gland. And you can see that these are very different. And this really is a little invasive carcinoma that seems to be associated with this adenoma, also in a lymphoglandular complex. Now, if you look around the outside, sometimes these have wisps of muscle, and you may get stuck, well, is this really in the submucosa or not? But applying the same criteria that we did before, this one does, it's forming well circumscribed islands, but it may not look too well differentiated, but it's only minimally invasive. Now, this one's a bit unusual because I'm just going to pull up. So this is a mismatch repair. This is an MSH2 stain because this patient also turns out to have Lynch syndrome. And again, you can see the background stromal cells are staining nicely. The adenoma is not staining. The adenoma in the lymphoid aggregate is not staining. And the little areas of carcinoma are not staining either. This is actually a mismatch repair deficient carcinoma, which also likely means it's not going anywhere. I have to tell you, this is the first one I've ever seen with a carcinoma in, and I'm really relieved that it's MSH2 deficient. It means it's not going anywhere and you can just ignore it. And if I go flick back to the H&E, you can see this is minimally invasive. There's a second criteria here that's worth noting, that carcinomas that invade less than 1 millimeter really very, very rarely metastasize. And also those that are confined to the head of the polyp rarely metastasize. So this is really a curiosity, and it's really in there just to remind you that adenomas can have misplaced glands in these little lymphoglandular complexes, and don't worry too much about them. Okay. So oh, did the same one twice. Okay, so in this group, so now we've moved off. So I'm looking to see some surgeons insist to know the size of the carcinoma in these types of polyps. Okay, so question, how do you measure size in polyps? Not easy. The easy thing is if there really is a muscularis mucosae, you take it from the base of the muscularis mucosae. Otherwise, you end up trying to draw imaginary lines. The real question is, what are the surgeons going to use that for? Because is there a depth at which polyps are going to metastasize just because they're deep? And the answer is no, they really need to have additional features there. So in fact, the Japanese brought this in, and the Japanese are actually gently stopping using it, because when you get little carcinomas where the muscularis is completely destroyed, there's no easy baseline from which to measure these. The best you can do is hopefully see where the muscularis mucosae might have been at the edges and measure it. Similarly, the other question is, do you want to measure the distance from the resected margin? And that can be helpful in that if it's more than 1 millimeter, then those lesions are pretty well completely excised. Under 1 millimeter, you do have to worry that there may be residual carcinoma the other side, and that may not always be present in the sections that you have. Okay, let me pop that back down again. Okay, so we've now moved into the other end of the GI tract. So now we're in the stomach. So we have 6 pieces of tissue here. If I look at the one in the middle, you can probably see pretty easily. So it's gastric type mucosa, all simple mucus producing glands. So it looks as if we're in the antrum. If we look here, you can see the endocrine cells with their nice halos, and it's in the mid part of the crypt. So you know you're in the antrum. Notice there's no inflammation. If I flip up to the top fragment, my screen is mucking around again. Tell you what, let me just close this and cut losses. Okay, so this one at the top, also antrum. You can see the G cells, no inflammation. And at low power, you look at the bits at the bottom, and these also look like antrum. There's obviously no oxyntic mucosa, but they are inflamed. Now, when you see this combination of gastric biopsies that at first glance all look like antrum, except some are inflamed and some aren't, by far the easiest explanation for this is that this is not Helicobacter, because Helicobacter does not give you this exquisite inflammation, this pattern of inflammation with nothing in the antrum and inflamed mucosa in these other body parts, other biopsies. So when you see this, the knee jerk should be, this is atrophic oxyntic mucosa. So this is really atrophic gastritis, possibly autoimmune gastritis. So can you back that up on an H&E? And the answer is you can. Now, if you look at these glands down here, these look very much like the typical antral glands that we just saw. If you come across these aren't, these have very little mucin. And if I flip up, you can see there's a second characteristic here, which is that these look multi-layered. You've got sort of an outside layer and an inside layer. And this thing tells you that the outside layer is actually endocrine cell hyperplasia. This is ECL hyperplasia. And if I run across to some of these look like more like typical antral type glands. This one's got a double layer around the outside. Notice the low power architectural disarray. So if this was in the colon, this would look like ulcerative colitis with architectural distortion. So you can look, wherever you look here, you can, see, this is probably a little endocrine micronest, but you can see a little bit of residual oxyntic mucosa, probably. This one has a lovely double cell layer. So look for the double cell layer. The double cell layers tell you right away, yes, this is atrophic oxyntic mucosa, and this is endocrine cell hyperplasia, which means the patient is hypergastrinemic. Now, if you have a gastrin stain, that can be really useful, because if you do that, it will light up and tell you these are G cells, and there's not a G cell to be seen in these, unless there is intestinal metaplasia. If you get intestinal glands, you can get G cells in intestinal glands, but not otherwise. Now, I'm going to assume that you don't have access to that. So this is a synaptophysin. This is the original antral biopsy, and you can see this lovely mid-zone pattern. There are actually a lot more G cells than you normally expect. And not only that, they're actually starting to form these little nodules, which is exactly what you see in G cell hyperplasia, these little nodules. If I go up to the other part, same
Bob, can
thing.
you expand the screen, please?
I'm sorry, thank you. I keep forgetting to expand the screen. Thank you for, keep telling me to do that. Thank you. So you can see the G cell hyperplasia. If I flip down to the other end, again, remember this is chromogranin, and you can see here linear hyperplasia, and you can see these double cell layers, and you can see that the outside layer is endocrine and the inside cell layer is not staining. So a chromogranin or a synaptophysin, we usually do both, gives you both of these. So this confirms the diagnosis. Now, why is that important? Well, patients with atrophic gastritis often are not making very much in the way of acid, which means not only can they be B12 deficient, but they can be iron deficient as well, so they may have a mixed anemia. You certainly don't want them getting subacute combined degeneration or something like that, which fortunately we don't see these days very often. But these patients are at a low but definite increased risk for adenocarcinoma, not so much NETs, although you can get little endocrine nodules. I think if I flip down to a lower power, this other one at the side here does have some little endocrine micronests. That's absolutely fine, just confirms the diagnosis. For some reason, our synaptophysin stains our goblet cells like a MUC2 stain, but that's okay. It just tells you this one does have intestinal metaplasia. But these patients do have a lifetime risk of intestinal type gastric carcinoma going through dysplasia in the region of 6%, 5%, something like that, which is about all of our lifetime risk for getting colorectal cancer. And it's just so easy to pop down the scope every 2 or 3 years. Usually when we make this diagnosis for the first time, we suggest they go back and sort of have a really good look to make sure that aren't any plaques of dysplasia anywhere. And sometimes take biopsies along the whole of the greater curve and the lesser curve. The greater curve is important because sometimes these lesions are precipitated by Helicobacter, and you may still have Helicobacter in the upper greater curve. And of course, if it's there, you can eradicate it, and there may be a degree of reversal of this. But in practice, what you also need to do is the antibodies for intrinsic factor and parietal cells, just to ensure that this isn't part of an autoimmune gastritis. The anti-parietal cell antibodies are probably a cross-reaction with Helicobacter. But often these patients have other autoimmune diseases, thyroiditis, sometimes adrenalitis, diabetes, and so on. But anyway, the combination of inflamed and uninflamed biopsies, think AIG. The second reason you need to know about this is in patients where you find intestinal metaplasia, just have a look at the background mucosa and make sure you're really in the antrum and there's not AIG in the background. The third location is in patients that have little NETs or big NETs in their stomach. These come in a couple of guises. One of the are the sporadic varieties where the background mucosal is normal or has Helicobacter, but the others are either associated with Zollinger-Ellison, where you get a huge, great, thick parietal cell zone, and you'll get exactly this sort of hyperplasia at the bases of the crypts in the parietal mucosa, but much more frequently you'll have this in the background. So whenever you see an NET, the question is always what's going on in the background mucosa. And if you have background mucosa, you can often see changes just like this in the background, and it tells you that this is a little NET arising in atrophic gastritis. They don't go anywhere until they're at least 1 centimeter in size. Don't do an MI, a MIB1 or a proliferative index. I know it's a knee jerk, but you know what you're going to do if it's a grade 2 lesion. There's no algorithm for handling those, and they really are a size dependent phenomenon. Okay, so I think that's all I have to say on atrophic gastritis, but this combination of inflamed and non-inflamed, and they all look antral, please think autoimmune gastritis. Okay, so let me just close that lot. Okay. So we're back into inflamed stomachs that are not Helicobacter associated. This one looks like good oxyntic mucosa. And you can see here there's quite a good focus of chronic inflammation. If you look at it, it's not residual oxyntic mucosa. You can see it's sort of lymphoplasmacytic. No destruction. If I flip down to the next biopsy, let me just back off a little. So same sort of thing, but notice the focality, the one in the center here, heavily inflamed, not very much inflammation here. This one has some focal inflammation. Now, when you're dealing with focal gastritis, one of the things that always crosses your mind is this so-called focal enhanced gastritis, which means you have a little collection primarily of lymphohistiocytic cells, plasma cells, sometimes with neutrophils. If we flip into this one, maybe the odd neutrophil. And when they're like this, most of these are idiopathic. In kids, you certainly have to think of Crohn's, and in adults, once every blue moon, perhaps 2% of adults with IBD can have lesions like this in their stomach. What they don't have is this really severe gastritis. And if I go down to the third fragment here, you can see the same thing. There's really a severe gastritis, lymphocytic gastritis. Helicobacter stain is negative. Now, when you have negative Helicobacters on what should be, or what you think should well be Helicobacter, the first thing that has to cross your mind is this a lymphocytic gastritis? Because lymphocytic gastritis is often, not always, but maybe Helicobacter related, and if you eradicate the Helicobacter, you get rid of the disease. This one you can see there's barely an IEL to be seen, so this is not lymphocytic gastritis. So once you're past lymphocytic gastritis, now you're concerned, could this be a medication-associated gastritis? And the two medications that do this are sartans and checkpoint inhibitors. Now with both of those will all give you some sort of disease elsewhere in the GI tract. And in this one, we've actually got some duodenal biopsies. So here are the duodenal biopsies. Really, duodenal biopsies? Yeah, you can see the Paneth cells at the basis of these crypts here. So these are duodenal biopsies, but they're flat as a pancake. Okay, if I flip down to one of these, whoops. So if we look at the surface here, you're thinking, this is celiac disease until proven otherwise, and you're absolutely right. And if you look at the epithelium, there's a decent number of intraepithelial lymphocytes. So this goes along quite nicely with celiac disease. If you look in the lamina propria, a lot of neutrophils in the lamina propria. That's unlike celiac disease, but you can get it in celiac disease in patients that, if you remember the good old x-rays, have those big dilated loops of bowel. They can get bacterial overgrowth and they will not respond to a gluten-free diet until you eradicate the bacterial overgrowth. So it's worth recognizing. However, this one's unusual because the acute inflammation is really quite deep and it's a peculiar inflammatory infiltrate, and the gastric lesion of celiac disease is a mild intraepithelial lymphocytosis, not the great big disease that we've got in this patient. So in this patient, you have to be concerned, is this patient on olmesartan particularly? So you go dig out the chart and sure enough, this patient is taking olmesartan. So this is a combination that you have to recognize. Now, in this one, the neutrophils are nicely developed, but they may not be well developed. In fact, it can be an absolute mimic for celiac disease. Usually the celiac serology is negative, or it may be very low titer. But when you're dealing with these peculiar serology negative celiac diseases, just bear in mind, olmesartan particularly. Olmesartan's a really common drug. It can give inflammation, IALs, throughout the GI tract, can cause lymphocytic colitis, collagenous colitis, so all of those. And all you need to do is change the medication. Most of the clinicians are switched onto this now, but we actually had one a year ago. The patient had been in hospital for 18 months with unresponsive celiac disease, negative serology disease. So it's something you have to think of in patients that have something that looks like celiac disease. And as I say, checkpoint inhibitors are the other thing that can do both of these lesions. Okay, in the last few minutes, so this is a biopsy of a gastric erosion. And you can see this is a big league erosion. You can see the erosion on the surface. You can see there are neutrophils under the surface here. You can see there's degeneration of the gastric pits. You can see it's oxyntic mucosa. You can see the residual chief cells in there. It almost looks like PPI effects, but notice the lack of chronic inflammation. When you get this sort of destruction, the cells often fall into the lumen. This one has quite a lot of neutrophils in there. So this looks like a chemical injury. So this is going to be a pill gastritis of some sort. Now, NSAIDs are usually excuse me, fairly characteristic because they have a great big zone of fibrinoid necrosis across the surface. This one is interesting because you can see these little capillary loops that have fibrin in them. And these are worth looking for because whenever you find these, this means the patient's taking doxycycline. So there are a couple of nice papers in the literature, but now whenever you get a pretty severe reactive type gastropathy, gastritis, particularly where there are erosions, have a look for these little capillaries. This one is fairly subtle, but you can see it's there. And this is always doxycycline. Haven't seen one of these that's not doxycycline. So just a little tip, you look like a hero, you just tell them, this is doxycycline injury. Is there any way you can switch the antibiotics to something else? That's one of those little spot diagnoses. But notice the degenerative changes. It's a little bit focal. There's another piece of oxyntic mucosa that's a bit more of a fairly typical reactive gastropathy here. Again, note the lack of inflammation in the background. So just a little tip. And the last case.
I'll just remind to all attendees to put their questions in the chat.
Okie doke. Okay. So we're now down at the other end. So I'm going to completely mislead you by telling you that this is these are biopsies from a rectal mass, and it was sent to the surgeon for biopsies, and the CT was done, and the patient had a 6 centimeter lymph node in the draining area, and the surgeon took one look at it and said, looks like cancer, I'm taking biopsies, which he did, and you can see there's not a hint of carcinoma. These are all really markedly inflamed. No architectural distortion. Notice the crypts are still nice and test tube-like, but they're pushed apart, and there's just a ton of deep chronic inflammation. Primarily lymphocytes, that's always a bit disturbing, but you can see there are a few plasma cells mixed up with that. And it doesn't matter where you look in this, they're all the same. A lot of deep inflammation, lamina-propria inflammation, it's all pushed apart in this mass with a 6 centimeter lymph node. So the question is, what does that? And you're allowed one immunostain. Which is this one. It shouldn't matter where you look here. Okay, here you go. So you can see all these, here we go. So you can see all these organisms. This is a stain for Treponema pallidum. And you always have to keep syphilis in the back of your mind. This is actually increasing quite markedly in our society. And whenever you get weird inflammatory things, always think of syphilis. This one came in earlier this year, and it was a disconnect because the mass looked like carcinoma, big lymph node, and all disappeared with a bit of penicillin. Okay, so that's my last slide. How are we doing for time? A couple of minutes. Let me see if there are any questions there.
There is one question.
Yeah, okay, so do you comment in your reports the post-polymer perspective of different types? No, we don't do that because the clinicians are very well aware of those criteria. They earn their bread and butter for booking their follow-ups in the next period of time. Excuse me, so we don't do that.
Bob, there is another question. Do you ever use MMR IHC to help support an SSP/SSA interpretation versus hyperplastic in difficult serrated polyp cases?
Good God, no, is the answer to that. Yeah, I can understand why you do that. That would be a very expensive way of doing it. Certainly not all sessile serrated polyps do that, and it's often only the ones that give rise to dysplasia. So I think that's a fairly expensive way of doing it. Usually, if you're a bit stuck and not sure, the easy thing is just to run a few levels, and if you find a boot in there somewhere, you're home and dry. Okay, so I think we're just about at time. So I think during this course, we ran through the goblet cell variant of hyperplastic polyp and then serrated lesions with and without benign fibroblastic polyps and perineuromas and the differential diagnosis. Do an S100. the things that you can do, you get combinations of all sorts, and you get polyps that get misplaced into the submucosa, and you can get focal dysplasia that may or may not be mismatch repair competent or not. Some of them are unclassified. We ran through malignant polyps and trying to keep patients out of trouble, particularly if there are no high-risk features. And then sartan-induced enteropathy, gastritis, to drug-induced changes, the diagnostic features of doxycycline, and then bear in mind syphilis at the back of your mind for anything that's a bit weird and wonderful, always worth thinking. So I hope you got something out of that, and I hope I didn't go too fast for you.
No, I think it was an exceptional presentation and very practical, and we have a lot of thank you for your excellent presentation in the chat here and Q&As. And needless to say that Dr. Riddell has multiple awards, multiple teaching awards over the years from OAP, University of Toronto, from many other societies, and even from the University of Sardinia.
It's a lovely place to go. It's a lovely place to go.
Yes. So I don't see any questions in the chat now, and we'll move with the rest. So if there is anything, I'll just email you and ask to provide feedback, and we'll email back to the attendees.
Thanks very much for inviting me. It's been
Thank
a
you
pleasure.
so much. Thank you.
Thank you.
So I'll ask Russ Price to introduce our next speaker. Russ, are you here?
He's muted.
Oh, yes. Russ, you're muted.
Can you hear me and see me?
Yes, we can hear you.
You can hear me, can't see me. Okay.
No.
That works. Thanks, Anna. It's my great pleasure today to introduce Dr. Donna Bailey, who Dr. Bailey is a fellow of the Canadian Academy of Clinical Biochemistry and the American Board of Clinical Biochemistry. In her day-to-day work, Dr. Bailey is a clinical biochemist at Dynacare Laboratories, where she provides scientific support and leadership for 5 laboratories across Canada. In addition to this, Dr. Bailey is the Vice President of the Ontario Society of Clinical Chemistry and the Certification Chair for the Canadian Academy of Clinical Biochemistry, in addition to being a lecturer at the University of Toronto. She is also the Secretary for the Canadian Society of Clinical Chemists Reference Interval Harmonization Working Group and the Special Interest Group in SARS-CoV serology testing. So today, Dr. Bailey will be speaking to us on harmonization of reference intervals. And although she may have the perhaps unenviable position of being the last speaker on the agenda, the topic is of such clinical importance. I'm sure that the meeting will end with a virtual fireworks of display, or display of fireworks, I should say. Anyway, this all kidding aside, is a really transformative initiative coming from the Canadian Society of Clinical Chemistry, which I'm sure she will show us will translate into better care for all patients across the country. Over to you, Dr. Bailey.
Perfect. And just to confirm, you can hear me and you can see my screen.
Yes.
Wonderful. So first, I'd like to thank the organizing committee for inviting me to speak on behalf of the CSCC Reference Interval Harmonization Working Group. I was able to attend yesterday's sessions and also today's sessions, and all the talks have been outstanding. So really congratulations on putting together a wonderful virtual symposium. So with that, I'll give you my disclosures. I don't have any disclosures regarding this, the data that we'll go through today. However, I do have to recognize I am a paid employee of Dynacare, which is a subsidiary of LabCorp. I also want to acknowledge that the ideas and the information that I'm going to communicate are on behalf of the CSCC Working Group on Reference Interval Harmonization. It's quite a mouthful to say, so for the duration of the presentation, I'll refer to us collectively as the HRI or the HRI Working Group. And seeing that this information is coming from a bunch of chemists, it will be focusing understandably on chemistry analytes. If you have any questions throughout the presentation, please feel free to put them in the chat box, and we'll address them either as they come up or at the end of the presentation. So in terms of learning objectives, I am a huge, passionate learner about reference intervals and appropriate reference intervals. Dr. Price, I thought your introduction was very generous because even within the realm of clinical chemists, there's those of us who are very passionate about appropriate reference intervals, and there's everyone else. So I'm really eager to learn that there's another group of individuals out there who may share a common interest with those of us who really see the importance of harmonized reference intervals and appropriate reference intervals. So for learning objectives, what I hope to show you is the importance of harmonization of reference intervals in lab medicine, to identify which analytes and what criteria can be used to distinguish analytes that are appropriate for harmonized reference intervals, review and compare and contrast methodologies available for reference interval determination, and be able to summarize what our short-term and long-term objectives are coming from the working group. Now, our project overview, it's demarcated into 7 distinct phases, and it is defined or laid out using the DMAIC cycle. I'm sure you're familiar with it: define, measure, analyze, improve, and control. So what we're going to do over the next hour is walk through essentially the journey that the working group has taken to date, and we'll touch on each of these phases, some in more detail than others, and it'll bring us to our current state where we're just finishing up our analysis and our recommendations for harmonized reference intervals. So the first thing within our define, and the first thing you need to do with any journey, is get your team together and identify what it is that you want to accomplish or where it is that you want to go. So to introduce ourselves, the CSCC Reference Interval Harmonization Working Group is a collection of clinical chemists and medical biochemists all across Canada. We meet regularly, and our objective is to establish evidence-based harmonized reference intervals, support their implementation in labs across Canada, and also ensure they are maintained once implemented. So I'm going to ask Heather to put up our first poll. Now, you know a little bit more about our group. What I'd like to understand is, from your group, what's the extent of your familiarity with reference intervals? Do you define reference intervals routinely as a part of your job? Do you not necessarily set up reference intervals, but you're familiar with them in terms of the approaches used to define them? Or are they completely outside of your scope of practice, but you do rely on them either professionally or personally when you are making clinical decisions or even reviewing your own lab results? So we'll give you just a minute to respond. All right, Heather, do you want to close that poll, please? And if we can see the results. All right, so we have a couple individuals who define reference intervals as a part of their job. A third of individuals who are familiar with the statistical approaches, and the majority who don't have any direct interaction with them, but rely on them either personally or professionally. So seeing that there's a mix of familiarity, I'll provide you some background regarding the landscape within Canada for harmonized reference intervals or clinical lab testing for chemistry. So within Canada, we have 5 major automated chemistry platforms: Roche, Abbott, Siemens, Beckman, and Ortho. And for each of these, the reference intervals are set by each laboratory. Within our accreditation requirements, the reference intervals used should be verified by the lab on a continual basis, but this is done to varying extents and through various mechanisms depending on the laboratory. What I always think is interesting is that within the clinical chemistry realm, we spend a lot of time ensuring that our analytical results are accurate, but we don't assess whether or not the reference intervals about those analytical results are accurate. So there's no mechanism right now to verify the accuracy of a reference interval through a third party or quality assessment scheme or accreditation. And then the last item to understand is that there are multiple ways to arrive at a reference interval, and we're going to walk through some of those ways. Now, if you were to ask an individual on the street, or even most of my physicians, which are family physicians who use Dynacare, their understanding of reference intervals, there's some very common misconceptions. The first is that they're accurate and that those values are set in stone, or that they could be looked up in a textbook. The second is that they're constant for a given test. So regardless of where the test is performed, on what instrument, the reference interval would be the reference interval would be the reference interval. Another common misconception is that if a reference interval between labs is different, that would imply that the lab is using, or the two labs are using, two different platforms. Now, as lab professionals, you know that these aren't always the case. And we recognize heading into this initiative that there was kind of an unknown or lack of quantitation of how discrepant reference intervals were across all the labs within Canada. So the first step that we took was to release a national survey, and we requested labs from across Canada to participate. The survey consisted of two objectives. The first was requesting labs to provide their reference intervals for 7 analytes. These are common chemistry analytes: ALT, ALP, calcium, creatinine, free T4, and sodium, as well as hemoglobin. We also requested that the participating labs measure 6 of these analytes within reference samples that were provided to them. And what we did was to compare the discrepancies in the reference intervals that they provided versus the discrepancies in the analytical results obtained. And the conclusions from this study is that there was significant variability even within the same platform for the reference intervals being provided by labs across Canada. And that this variability, it exceeded the variability of the analytical test results themselves. So just to drive this point home and give you a visual representation of the survey results, what we see here is the results for alkaline phosphatase, and I'll tend to use alkaline phosphatase throughout the presentation. And we have reference intervals for a 2-year-old male, a 14-year-old female, and a 50-year-old male. The instrumentation is categorized by color. So you can see Siemens, Roche, Ortho, Beckman, and Abbott. And the reference intervals used by each of the responding laboratories is shown in the horizontal bars. Now, what I hope you can readily see is, particularly in the case of pediatric reference intervals, but also to some extent in adult reference intervals, there is variation in the reference intervals used by laboratories, even if they're on the same platform. So looking at this outlier group for ortho, or this one here as an example for Siemens. As well, if we were to take an average of the reference intervals across all groups, we may land on similar reference interval, lower and upper limits. But when you look at variation from lab to lab, you see significant variation at both the upper and the lower reference intervals. So now we were armed with evidence and an understanding that the picture of reference interval harmonization in Canada was not a very good one. We had significant discrepancies between laboratories on how they were reporting. And if the reference intervals aren't accurate, then the analytical result also is not accurate in terms of its interpretation. So the next thing that we wanted to identify is whether or not, in theory, harmonized reference intervals for chemistry tests made sense. And in order to make that conclusion, we had to demonstrate that across platforms, so each of the vendors and across laboratories, you could expect and anticipate the same analytical result for the same test, no matter where it was done. In order to investigate this and make this conclusion, we selected 24 routine chemistry analytes, and they all had evidence through the literature to support harmonization. We did an evaluation of each for the platforms used in Canada, where we compared the method, the manufacturer, the calibration traceability, as well as the reference method. And through this analysis, we determined whether or not the analyte was a candidate for harmonization. So it was decided that if the method or the calibration or the reference method were equivalent, then the assays were appropriate to be harmonized and to have harmonized reference intervals. So here's an example of the worksheet, one of the worksheets that was completed, in this case for chloride, where we have all of the information pertaining to the test being used across Canada depicted. So you can see the methodology as well as the manufacturer and the model, the calibration traceability, and the reference method. So in terms of chloride, most of the methods are through indirect ISE, and all but one are traceable to the standard reference material 919. So given this information, we would conclude that chloride is theoretically appropriate for reference interval harmonization, as the results for chloride, regardless of the lab, should be standardized. So as I said, this approach was applied to a total of 24 analytes. These were analytes including electrolytes, renal markers, hepatic markers, and endocrine and lipids. Now, notably for endocrine and for lipids, for the analytes highlighted in black text and underlined, there are already clinical decision points available, and therefore there's no need for harmonized reference intervals. In the case of lipids, however, we have undertaken a separate project to work in collaboration with the Canadian Cardiovascular Society to standardize the reporting of lipids on laboratory reports, regardless of the location. Through our surveys and through other analysis, we have demonstrated that there is discrepancy in lipid reporting, and this is a separate talk that I would happy to share at a later time. So focusing on the remaining analytes, we now had candidates where we felt that harmonized reference intervals make sense and would be appropriate. So the next poll, if I can get it brought up, please, is to ask you what other analytes you would have liked to see addressed. Are there any analytes where you see frustration, either professionally or within your laboratory, that you think we should have harmonization and harmonized reference intervals? Whether it be hematology, additional endocrine markers such as sex hormones, additional renal markers, or vitamins. So Heather, if I can just get you to bring that poll up, please. All right, so we'll just give you a couple seconds. I think you can only pick one based on the layout of the poll. So go ahead and pick your favorite one. All right, Heather, for the sake of time, we'll just close that poll. All right, so most people would like hematology to be tackled. Definitely in agreement, and hopefully that'll be one of our next initiatives that we can undertake. So thank you so much for that feedback. All right, so we had our analytes in hand. We knew which ones we wanted to standardize, and now we had to decide on the approach. There's really two schools of thought, or two main methods for defining a reference interval. The first is the direct approach, and under this approach, you select healthy reference individuals using defined inclusion and exclusion criteria. So in this case, you would recruit individuals, assess their health through a survey, and decide whether or not they would be included or excluded from your reference interval study. On the other hand, the indirect approach, it uses already either existing samples or existing data, and it allows a retrospective data review of stored patient data. So just to go into each of those in a little bit more detail so that you have a good understanding of what our options were. So here I'm giving you an outline for the approach for a direct reference interval. As I said, in this case, you would have exclusion criteria and inclusion criteria, and have an REB approval to recruit individuals in order to participate. You would draw your samples and do the measurements of the analytes in question, and once you have your data in hand, you would start your statistical workflow. So the first step within the statistical workflow is to inspect the data visually for age and sex partitions, and then remove any outliers for the partitions or estimated partitions using a multitude of statistical approaches. Once you have removed your outliers, you would then confirm your age and your sex partitions using the Harrison-Boyd method, and then do your calculation for your 2.5th and your 97.5th percentiles. For those of you who aren't familiar with the definition of what a reference interval is, it's exactly this. It would be the 2.5th and the 97.5th percentile of a healthy population. So using the direct approach and the statistics with the direct approach, if you have over 120 samples per age and sex partition, you can use the non-parametric rank method. However, if you have a smaller sample size between 40 and 120 individuals, then you can use the Horn and Pest method, also known as the robust statistics or bootstrapping. And once you have your upper and lower reference limits in hand, you would lastly calculate your confidence intervals about each of those reference intervals. So to depict the same information only visually, I'm just going to walk you through the graph here. So for the non-parametric approach, you would collect your individuals and identify the appropriate age and sex partitions. Ideally, you would have more than 120 subjects per age and sex partition. You would then rank them from their lowest to their highest concentration and identify the individual occurring at the 2.5th percentile and the 97.5th percentile. And these would become your lower and your upper reference intervals, respectively. So that is how the direct approach works, and it is endorsed by CLSI. And we've had tremendous success with it, particularly within Canada. Many of you may be familiar with the caliper studies being undertaken at sick kids, where they have defined reference intervals for pediatric patients for just about the complete menu of chemistry analytes. It was a huge initiative, and it has been tremendously successful to fill in gaps for pediatric care. As well, there is the Canadian Health Measures Survey, or the CHMS, which also uses the direct approach to calculate reference intervals, but this time in the adult populations. So looking at the pros and cons of direct reference intervals, the advantages are that they're very well controlled. You can control all components of the study, including the recruitment process, the collection process, the sample storage process, the sample analysis, doing it within one run to minimize any variability, etc. The direct approach reflects a healthy population as identified through your screening measures. And as I mentioned, your pre-analytical variation is very well controlled. However, as I'm sure you can appreciate, it requires a huge cost and time investment in order to recruit all of these healthy individuals and also run all the necessary tests or test panels on their samples, making it really only feasible for a small sample size. So the minimum number of samples is 120. Realistically, you would have to recruit maybe 600 subjects, go through the screening measures, and once you have age and sex partitions, you might have enough individuals for each partition. As well, it can be very complicated in some circumstances to define health. You can't give a limitless list of inclusion or exclusion criteria. So typically you focus on those that are relevant to your study in question or your analytes in question. And then the last disadvantage is there's significant barriers for direct methods in pediatric and geriatric populations. As a testament to the efforts of Caliper, obtaining pediatric specimens, blood samples from healthy kids is no easy feat. And on the flip side, for the geriatric population, it can become quite difficult to identify or even define what's considered a healthy geriatric individual. All right, so I hope that you can appreciate the benefits to the direct approach and recognize the significant limitations. and that you are asking yourself, well, we sit on mounds and mounds of data within the laboratory. Can we use the data that we already have? And the answer, of course, is absolutely. And this is where the indirect methods for reference interval definition come into play. There's kind of two approaches underneath the indirect methods. The first is where you take your data set, your pre-existing data set, and before running any statistics, you try to separate out who is healthy from who has a pathological condition. And this can be done by either relying on data sets from healthy donors, as an example, so blood donors or individuals in the hospital for minor surgical procedures. Or you could try to extract data from mixed data sets. So those data sets that include both healthy and pathological results. And in this case, you may do a chart review and identify any relevant diagnosis as exclusion criteria, or you may include or run additional tests that could be used to exclude an individual if they are in fact abnormal. So this is one mechanism of the indirect approach, but as I think you can appreciate, you're also limiting your size if you have to go through the data and make a decision on who's considered healthy from unhealthy before you even start your statistics. So the approach that's really gaining a lot of traction now is the use of what's called a mixed data set. So in a mixed data set, you have both your healthy and your pathological, and you use statistical modeling in order to identify who's considered healthy from who's considered diseased or separate from the healthy group. And as I said, this latter approach, you can also hear it referred to as a mixed modeling approach, is gaining increasing traction. With the advent of very sophisticated computational statistics, clinical chemists and other laboratory statisticians are very interested in mining big data and trying to achieve harmonized reference intervals. So this was just published in June 2020, and it's available for you to read on the AAC website. If you have a couple minutes, it gives a really great overview of the initiative that we're undertaking and gives you some background information that we can't necessarily touch on today just as a result of time. So when we look at these mixed data set statistical modeling options, there's a couple aims that we hope to achieve with a statistical tool that's been selected. So the first is that the tool has to be able to identify and separate mixed distributions with a high reliability and accuracy, but in a non-subjective manner. We don't want to leave it up to an individual to decide or identify whether or not someone should or should not be included, or a portion of the data set should be included. We also want to have minimal statistical assumptions. So in statistics, we talk about a Gaussian distribution. That's an assumption of a distribution. It affords us additional power in our statistics, but it may not always be the case, or those assumptions may not always be met. So we acknowledge that the normal or the healthy population in most of these, or I think all of these statistical options, they require that the healthy population is normal or Gaussian, but it would be best if we don't have to make any assumptions about the distribution of the pathological values. And then the last item is that we want a tool that evaluates the goodness of fit. When we apply the statistical model and we come up with a proposed reference intervals, we want to make sure that those reference intervals can be applied to a second data cohort or a third or a fourth, and they don't either overfit or underfit the data. So here are some of the tried and true statistical methods that have come about within the field of clinical chemistry and laboratory medicine. Arguably the most well-known are the Hoffman and the Bhattacharya approach, and the most recent one, and the one gaining the most traction, is the Arzadeh method, or the method established by Arzadeh and colleagues. So we're going to compare and contrast each of these, just as you have an understanding of what our options were in terms of tools to use to define the reference intervals. This is of particular importance because if you don't believe me on the selection of our statistical tool, I really don't have any ground to argue that the reference intervals we've proposed are appropriate. And that's the reason why we're going to spend a little bit more time on these statistics. All right, so looking first at the Hoffman approach, it was described in 1963, and at that time it was performed by eye, so really a pen and paper method. And with this method, it's also known as a QQ plot. You plot the cumulative frequency of your distribution on a normal probability paper, and the y-axis has a non-linear scale. And that y-axis scale is set in such a way that the data following a Gaussian curve or a normal curve, it gives a straight line. So you can you can see in panel A, we have a hypothetical data set, and you can imagine visually the Gaussian curve within the center of that data set. At each of the tails, we have some outlier population or a second and a third population, and those are very clearly depicted in the Hoffman plot on panel B. You can see the diagonal line of best fit, and it is fit largely to the median or the central portion of the data. And you can see the tails, the non-Gaussian, veering away from that line of best fit. So with the Hoffman approach, you extrapolate this line of best fit to the Y value corresponding to the 2.5th and 97.5th percentile, and you find the corresponding X values, and this provides you with your lower and your upper reference limits or reference intervals. So the Hoffman approach, again, it's been around for a really long time, and it's been used by many laboratories. But some of the limitations, or some of the most significant limitations, are that it is subjective to a certain extent to decide how to apply this line of best fit and to estimate the lower and the upper reference intervals. As well, it does not have a goodness of fit statistic associated with it. So the second statistical tool that we looked at was the Bhattacharya approach. This is also a quite well-aged statistical tool, described first in 1967. And it uses a graphical method that involves mathematically straightening the Gaussian distribution prior to plotting the data. The Gaussian component is plotted in a straight line, as you can see here, and any component falling off the Gaussian distribution will again veer from this diagonal line. Now, unlike the Hoffman approach, where drawing your cut points for the 2.5th to the 97.5th was somewhat subjective, in the Bhattacharya analysis, it's the slope and the intercept that are used to determine the mean and the SD, and from this, the reference interval. Now, there's been a lot of modifications of the Bhattacharya analysis. However, it is also limited in that it has a certain amount of subjectivity and no assessment of the goodness of fit. So moving from the 1960s over to 2020, we've definitely come a very long way. Rather than using these pen and paper, somewhat rudimentary statistical analysis, we can leverage modern computational power in order to derive our indirect reference intervals. And the statistic that we use is the maximum likelihood estimation. By no means am I a statistician, so my understanding is definitely very rudimentary. But what this maximum likelihood estimation essentially does is it's an iterative process where the probability distribution is fit to the data so that under the assumed model, the observed data is the most probable. And this maximum likelihood estimation has been implemented by Arzadeh and colleagues using what's called the TML approach, or the truncated maximum likelihood approach. So under the TML approach, the preparative step, or the first thing done, is to use a density function, and it allows the data to be smoothed out to give you a good distribution or indication of the distribution. The central portion of the data is then analyzed through a Box-Cox transformation. So this is done to deal with any non-Gaussian data or non-normal data. And then the mean and the variance are determined by this maximum likelihood estimation approach. And as I mentioned, it's an iterative approach, so it will continue until it finds the best solution or the best model that makes the observed data the most probable. And then lastly, the limits of the central component are defined using the Kolmogorov statistic, as well as giving an estimate of the goodness of fit of the model. So the TML approach definitely has taken advantage of computational and statistical power from the year 2020, and it overcomes some of the limitations that we've seen with the Hoffman and the Bhattacharya approach. So we gave you a visual example of the Hoffman approach, the Bhattacharya approach, and we're going to take a couple minutes and look at what the output of the TML method is as well, or the Arzadeh method. So in the left-hand pane, we have an example of what we would like to see within our data set. You have a histogram of your data in the background shown by the bars. You have your smooth data of your population in the dashed blue line. And then you have your fitted non-pathological distribution shown in the green curve. As well, you have a distribution where there is no assumption for normality for the pathological population on both the low end as well as the high end. And I did want to highlight that it is an advantage of the TML method that it gives you the borders or the limits of not only your normal population, but also your proposed pathological population. And we may see some attention being moved toward an understanding of the pathological groups in the future. So in the best case scenario, our healthy population, it follows this normal distribution. And there's only one peak, so it's only unimodal. What's also important is that the amount or the percentage of pathological samples is less than 20%. We definitely don't want it to be the majority of the data set. And it should not overlap completely with the tails of the normal distribution. We want a partial overlap, but not a complete overlap, because the statistical tool needs to be able to delineate where the pathological group ends and the healthy population starts, as an example. So on the right-hand side is what would not work with the TML method. In this case, we see the same type of scenario where we have our whole data set highlighted here in blue, but I think you can appreciate that there's two populations underneath this curve, one for potentially the healthy individuals and the other for the pathological. In this case, the percentage of the pathological values are greater than 20%, and so the tool fails to appropriately distinguish the upper reference interval or the cut point between the healthy and the high elevated pathological subjects. So again, this is the output that we expect from the TML method. And I think visually it's very intuitive as compared to the Hoffman approach, as well as the Bhattacharya approach. Now, when I introduced the indirect methods, I talked about some of the aims. And the TML method, it meets all of these criteria as we've just reviewed. It is able to separate mixed distributions, and is highly reliable and accurate, and there's no subjectivity. There's nothing that I have to do as a user of this tool to determine or make a decision on where the upper and lower reference intervals or reference limits should lie. It makes minimal statistical assumptions, and it doesn't require any assumptions of the distribution of the pathological values. And lastly, it evaluates the goodness of fit of the applied distribution without over or underfitting the data. All right, so now we've reviewed some of the methods for the indirect reference interval development. And I think you can appreciate the pros and also the cons of the indirect approach. The pros, so unlike the direct approach where we would have to recruit healthy individuals to participate, the indirect approach can be done at any time, so long as you have access to the data set or a data set that meets the criteria, so that where the pathological population is minimal compared to the healthy individuals. It also has the advantage that by using your lab data, it reflects the population of your laboratory, and it incorporates pre-analytical factors that may be unique to your lab. As I said, it can be completed at any time as soon as you extract that data, and it works best with very large sample sizes. And by doing so, it gives you increased confidence in the results and the statistics of those in order to arrive at those results. Now, the disadvantages, of course, are that when we use a mixture model or an indirect approach, we don't really know who was healthy and who was not healthy. So there was always the risk of erroneously incorporating a unhealthy subject or a group of unhealthy subjects or a second group entirely into your definition of the healthy population. And it would then broaden or skew your reference intervals. So something that we recognize, but without knowing the true health of these individuals, it's a limitation of these approaches. As well, we don't have any control regarding the pre-analytical specifications, the medications of the individuals used within the study, coexistence or multimorbidity, or test variation. And we'll touch on test variation a little bit more later on. Now, for I think obvious reasons, we selected and we moved forward with the TML approach. It does offer significant statistical and computational advantages. It offers the feasibility that we wanted, and it had another thing going for it. So if you are interested in calculating reference intervals within your laboratory and you do have access to your data set, this tool is readily available and freely available through at least 2 websites. The first is the German Clinical Chemistry Group, and you can download the tool as an Excel-based platform and run your data through. Or you can go to an online tool, and here you would just upload either a CSV file or an Excel file, and it would give you your estimates for your reference intervals in probably under 5 minutes. And these would be for population data sets upwards of even 20,000, 40,000, a million data points. So it's very user-friendly and freely available and endorsed by, as I said, the German Clinical Chemistry Group. All right, so where were we in our journey? We had identified the analytes where harmonization was appropriate. We had identified the statistical tool that we felt would do the best job of defining these reference intervals. And we decided to go with the indirect approach. So the next step was to get the data. We needed data from a large population of mostly normal subjects that represented the Canadian population and where results were consistent over time. We didn't want any fluctuations in the analytical results that would induce an error or a bias to our estimates of the reference intervals. So fortunately, we were able to collaborate with all of the large reference laboratories within Canada, where they have access to tremendous amounts of data, and their data points are largely from healthy individuals undergoing routine physicals and blood testing. So significant recognition to DynaLife in Alberta, Life Labs in BC and also Ontario, and DynaCare as well in Ontario. So what these labs were able to provide us with is 2 years of anonymized data where any repeat tests were removed. So by identifying individuals with their health card number, if they appeared more than once within a data set for a given analyte, they were removed so that we had only one data point per person per analyte over the 2-year period. And in terms of volume of data, I mean, we had millions upon millions of data points, allowing the statistical calculations to be very robust, even in the presence of multiple sex and age partitions. So now we have our data set, and we needed to define our workflow in order to apply the statistical analysis. So it's very similar to the one that I already went through for the direct approach. We retrieved our population data set, and it was segregated by each province. We then assessed the age and specific sex differences, as well as any province-specific or instrument platform-specific differences. And both were done using the Harrison-Boyd method. Once the partitions were identified, we cleaned up the data set by identifying any unstable months or any gross outliers. And we combined the clean data sets into a Canada-wide file. Once we had the Canada-wide population, we used the TML method to calculate our 2.5th and our 97.5th reference intervals. And we verified these proposed reference intervals by comparing them to direct reference interval studies such as CHMS, as well as other harmonized reference interval initiatives. So this is what the data looks like. We're going to go through ALP very quickly, just as an example. The first thing that we do with any data is take a look and make sure everything makes sense. So we used a combination of density plots, and here the highest density or population is shown in red, and lower density of the population is shown in blue. And I think you can get a pretty clear appreciation for two age-specific densities appearing on this density plot. We also used your standard scatter plot where we have age versus concentration. And to review any sex-specific differences, we relied on bean plots where we have male and female data depicted separately, but for the same age, and analysis of the means or the medians from each of those groups, as well as the variance associated with each of those groups. So these were the visual tools that were used to identify if we needed separate age or sex partitions in the reference intervals. In the case of ALP, we identified the need for 3 partitions, one for males aged 19 to 40 years, one for females 19 to 40, and a third for both females and males between 40 and 80 years. So having identified our age and sex partitions, the next question we had to answer was whether or not we could combine data from all the provinces into one complete data set. So we also used the Harrison-Boyd method, and graphically we reviewed the data using the bean plots as shown here. So again, we're looking at males and females separately from each of the provinces. And we're looking mostly at the distribution of these curves to make sure at the extremes, we don't get a different result if a population was left separately versus if it was included in the Canada-wide population. So once we identified the age and sex partitions and demonstrated that all the population data could be combined, we needed to go with a fine-tooth comb through our data and make sure there wasn't any information that would skew our results. And one of the big reviews or analyses that was required is to look at the month-over-month analyte stability. So what we see here is the median stability, or rather the median result for ALP, normalized to a target of 0. Our acceptability limit shown in the horizontal green lines, and the variance in that median ALP level from January 2017 to December 2018. In cases where the variance exceeded our tolerance limits, that month was not used for data analysis, and only the data which fell within the allowance limits were used. So what could happen or did happen, we assume in some cases, is that an assay, it may not have been behaving properly or been out of control, or there could have been a lot-to-lot shift or calibration or restandardization change. So the introduction of that data was minimized as much as possible. All right, so now we had clean data and we were able to combine all of the data sets and identify the reference intervals for each of the age and sex partitions using the TML approach. So what you see here is a representative output of the TML analysis for ALP for individuals between 40 and 80 years of age. As we walked through before, the total data set is represented by the dotted blue line, the healthy population by the green curve, and the pathological population in the red curve here. In the case of ALP for individuals 40 to 80 years of age, the appropriate reference interval based on this data set is 41 to 119. So the last step is to compare the data to other reference interval initiatives. And as I said, both direct as well as indirect. And our proposed reference intervals are shown in green. CHMS is shown in dark blue, and some other harmonized reference interval initiatives are shown in other blue colors. And happily, you can see that our method verifies and is appropriate in agreement with other studies. So this process was repeated for all of our analytes. So looking at the hepatic markers, the renal markers, endocrine markers, and the electrolytes to provide proposed harmonized reference intervals for each. And that brings us to where we are today. We have selected our preliminary reference intervals, and what we're moving toward is to solicit and obtain feedback from stakeholders and to validate these reference intervals in third-party laboratories. So what we are working on currently is to recruit 60 adult volunteers. These would be healthy individuals, obtain 2 serum and 2 plasma samples from each, and send out 1 ml aliquots to about 10 laboratories from across Canada, not associated with this project directly. And these laboratories have agreed to measure all 17 analytes on each of these samples on 2 matrices. And what we hope to accomplish with this verification process is first to demonstrate that the proposed harmonized reference intervals are valid across all laboratories, regardless of the platform used or the geography. And also to demonstrate that the results analytically, number for number, are equivalent across all of the platforms. And if we're able to verify these 2 components, we can say that harmonized reference intervals are appropriate and would be a significant improvement over our current state. Now, once we've verified it, our last step will be to implement and encourage labs to introduce the harmonized reference intervals. And once introduced, we will continue to maintain them as assays drift over time or any adjustments are made to assays over time. Just for the sake of time, I'm going to skip this last poll. I hope that we have gone through and met all of the objectives, our learning objectives, that you now appreciate the importance of harmonization, that you understand what criteria are used to define analytes for reference harmonization or reference interval harmonization. You have an understanding of the methodologies available, and you have an understanding of the objectives of the CSCC HRI working group. I would like to finish off by thanking the entire working group from the CSCC, particularly our co-chairs, Drs. Adeli and Collier, our statistician Shervin, and very importantly, all the clinical chemistry fellows who have spent many, many hours doing many, many calculations for many age and sex partitions for these 17 analytes. Without them, we really wouldn't be where we are today. So with that, I will stop, and I'm happy to take any questions or comments. Again, you can put them in through the chat feature. While we're waiting for those questions and comments to come in, My email address is shown at the bottom here. And if you or your laboratory are interested in participating in the Reference Interval Harmonization Initiative, or if you would like to receive details regarding our progress, please send me an email. We're always happy to have more members added to our team. And we really want to put Canada in a position where we're offering the best in care to our patients. And the best in care within the realm of clinical chemistry is really not just accurate analytical results, but accurate reference intervals around those analytical results. So again, I thank you very much for your time.
So I'd like to say on behalf of the OAP, thank you, Dr. Bailey, for a truly excellent presentation. As promised, it was outstanding. I think the CSCC should be congratulated for this really foundational work that is going to translate into better care for patients. And it looks like, Meredith, maybe there's some questions in the chat box.
Yes, there are some there, and we will, just so that everyone is aware, we will be posting the recording to our website so that everyone can access in our educational archives after. And I think that's it for now. If there's anybody else that has any questions, if you could submit it and we will ask. Okay, well, I think nothing else has come in. I think if we've got something that comes in a little bit later, we'll be sure to forward that off to Dr. Bailey.
Perfect. Thank you so much. And congratulations again for a wonderful virtual conference.
Thank you so
Thank
much
you.
for participating. Thank you.
My pleasure. Thank you.
So that presentation concludes our 3-day Ontario Association of Pathologists annual general meeting. I want to thank all the participants for being able to join, and I think we covered a wide variety of topics, so hopefully it was of interest to both anatomical pathologists, general pathologists, and subspecialty pathologists. If you have any comments or any critique, that it will be extremely valuable, so please do put evaluation forms and submit them for all of us. Will look at them very, very careful. And again, reminder, if you can pay your annual dues, that would be highly appreciated. Otherwise, this conference is free and the recording will be posted for members only portal on our OAP website. I will ask all the residents to stay behind. We would like to meet with you, with all the board members and the rest of the panelists and attendees. I would like to thank you again, and we hope to see you at our next events. And hopefully next year AGM will be in person. Thank you very much. It was a great conference.
And we want to also remind everybody who is on right now that they're welcome to stay to hear the poster presentation winners and to ask any questions regarding the posters that are available on the website. We will have all of our abstract presenters here to answer any questions you might have about the presentation recordings that they have.
But we definitely need all the residents and all the PA members who submitted an abstract to stay behind.
So I'm just promoting all of our poster presenters to panelists just now. So you're going to see them. And when you are as a panelist, you're more than welcome to turn your camera on so that those who are staying on the line can see you and ask any questions of your presentation. So Dr. Liu, did you want to go ahead and start your program?
Yeah, so welcome everybody. It's very nice to have this extra time for the residents and also for the board members have this opportunity to meet you all, our new generation. So is that possible you can have the image on for everybody? Like I want everybody to introduce themselves. I kind of a head count.
Yeah, they're all coming on just now.
Okay.
So maybe to give them 1 minute just to.
Yeah, that's good.
There, I believe we are all there now. So we've got Menno Gabriel, Amy Calavini, Shoshi Lee, Minji Zhu, Ariel Gershon, and Kyrillos Vergala.
Do I see their face?
Yep, they are all there.
Oh, great. Okay.
And if you want to see them all, just click on speaker view or the grid.
Okay, so we have here, shall we introduce ourselves first? Anna first, please.
Yeah, I think it's a good idea. So we would like to welcome you to our resident meeting. Usually it's either resident breakfast or some sort of a meal. And that would be a great opportunity for us to meet with you in person, hopefully next year. I'm Anna Plotkin. I'm the president of the Ontario Association of Pathologists, and I work at Sunnybrook Health Sciences Center in Toronto. Maybe I see, Russ, you're first in my squared view.
Well, you're always first in my mind. I'll take second, perhaps. Anyway, my name is Russell Price. I'm a general pathologist, graduate from the Queen's University program, and I've worked at the Royal Victoria Hospital in Barrie for, let's say, 25 plus years, and I won't say any more than that. I am the medical director here at the hospital, which I've been doing for most of those 25 years. And we're just so happy to have passionate young people joining the OAP and to speak with you today. So thank you for staying on for this session after.
Thank you, Russell. I just introduced myself, Nancy Liu, pathologist at Oakview Hospital for 20 years. And I'm also the OAP education director here. Welcome to our session. Thank you. Corwin.
Hi, I'm Corwin Rousel. I'm the vice president of the OAP. And I'm also the division head of pathology at Unity Health Toronto. For those of you not familiar with that name, that's St. Michael's Hospital and St. Joseph's Health Center in Toronto. And yeah, I'm just thrilled to meet you all. I look at you all as our future colleagues and would like to know more about you.
How about I finish the pathologist, a board member first? Andrea.
Unmute myself here. Hi, my name is Andrea Grin. I'm a pathologist in Kingston at Kingston Health Sciences Center. I did my pathology training in Toronto and worked there for a few years, and then moved to Kingston and been here for, I guess, about 3 years now. I recognize a couple of names from Kingston, but no faces. There's no camera on.
Thank you, Andrea. Do we have any more board members?
Yes, we have Susanna and Aurelia.
Oh, here.
And Antia.
Yes, hi, I can start. My name is Aurelia Busca. I'm a pathologist at the General Hospital in Ottawa. My main areas of interest are gynecological and GI pathology. And welcome to our residents. Thank you for coming and for joining us for this conference.
If I could just ask if there are any other residents sitting as an attendee, can you raise your hand, please? Because I'm trying to find everybody. And if you raise your hand, you'll scoot to the top of the attendee list and I can promote you to a panelist much faster. I think I have everybody, but I'm not sure. So if there's any more residents as attendees, please raise your hand so I can move you to panelist and we can see and hear you. Go ahead.
Okay, next, Susanna. Can you hear me, Susanna?
Hi everyone,
Yeah,
my name
hi.
is Susanna Gorski. I'm happy to be here. I'm a PGY2 in anatomical. Yes. I'm not sure. Can everyone hear me?
PGY2 anatomical pathology in which hospital?
At the University of Ottawa.
Thank you.
Sorry, I think my internet connection is a bit unstable.
Ansia.
Antia just texted me that she cannot, she's at the resident desk, so there is no microphone or camera there.
Oh, okay.
So Antia is not the resident. Antia is actually was our first resident board member, and she helped us a lot with the social media. Was an exemplary board member, and we really miss her because she's moving to her studies now, being PGY5.
Okay, so let's go to the residents. Next one is Mena.
Hi, this is Manal Gabriel. Can you hear me?
Yes, please.
Okay, I'm a pathologist.
Oh, I'm sorry.
Yeah, I'm associate professor at the London Health Science Centre, Western University at London, Ontario. I did my residency in Newfoundland. I moved to London like a long time ago. So I'm here.
Thank you. Next one, Ariel. Can you hear me?
Yes, yes, hello.
Hi.
You can hear me. Yeah, my name is Ariel Gershon. I'm a PGY2 in anatomic pathology in Toronto.
Welcome.
Nice to meet you all.
Yeah, next one is Aurelia.
Aurelia is our board member.
Oh, I'm sorry. I'm sorry. Okay, next one is Minko. Minkyu. Can you hear me?
It's Minky.
Yeah, Minky, please. Can you introduce yourself to us?
Oh, there's a message saying the audio isn't working.
Okay, yeah, so you can get back to us next time or later.
Nancy, did Aurelia introduce herself?
Yes, please, Aurelia, please.
Aurelia, we can see you. Can you unmute yourself and introduce yourself as a board member?
Yes, hi, can you hear me?
Yes.
For some reason, I thought I did earlier. I'm sorry. My microphone is playing pranks on me. I'm Aurelia Busca. I'm one of the pathologists working at the Ottawa General Hospital. I'm a recent graduate myself. I'm in my second year of practice now. My areas of interest are gynecological and gastrointestinal pathology. And this is my first time serving on the OAP board as a board member. Thank you all for coming, and nice to see everybody.
Thank you. Next one, Sauchi. Are you there?
Yes, I am. Hi.
Hi.
Sorry, my camera's not. I'm at the resident desk, so I don't have any camera. So my name is Xiao Shili. I'm a resident from Western. So I'm currently working at London Health Science Centre. Yep.
Welcome. Any more residents? Okay, good to move to Amy.
Hi, can everyone hear me?
Yes.
Yep, great. My name is Amy and I'm a pathologist assistant at Mount Sinai Hospital in Toronto. I'm also a recent graduate of the Western University's pathologist assistant graduate program.
Thank you. Next one, I think we're going to move to Carlos.
Hello, hi there. My name is Carlos. I'm a medical student at McMaster University. I'm in my third year now, and I'm interested in anatomic pathology. Thanks.
Welcome. Thank
That's
you.
wonderful. Are you related to Hala Faragawa?
Sorry, what's that?
Are you related to another pathologist that Corwin knows well, Hala Faragala?
No, not that I know of at least, but it's interesting to know someone shares my last name.
Keep in mind, you have already a connection.
Perfect, thank you.
Okay, so so we're gonna move on to the next stage, which I think we should look after the time also. It's the question and answer period. And I think board members, particularly Anna or others, probably will have some questions to the residents.
I think, again, for us, it will be extremely important to know how OAP can provide you support and what do you see us helping you with? Because you're all at different stages of your career. It's on one hand, and on the other hand, we would like to expand the opportunities for the trainees as well as the young pathologists. It's one of our goals, and that's why we're expanding our board members with residents and young pathologists or pathologists transitioning into practice. So please consider, give us some feedback. And then something like conference like that, did you think it's valuable for you? What was not working for you? That would be extremely important. What would be the topics that you as a resident would like to see on the future conferences? I think any one of you can answer. You can just hopefully start talking without us. Yeah.
I can say I really enjoyed, this is my first time participating in OAP, and I really enjoyed like the educational quality of the lectures that we heard today in particular. Like, I just found that very helpful, especially like having slides up and having an expert talk through them. I think like that is something hopefully you continue doing, but that's something I would be invested in as a resident, I would say.
That's great, thank you. Any other comments or any thought? Yeah.
Hi, if I can comment, I think it was really great that there was an interactive component in the form of the chat box, especially what we did with Dr. Bradshaw's presentation was when he would ask questions and residents had a chance to answer in the chat box. I was sitting in the resident room while we were all doing that, and I could see that there was a lot of participation in that.
Thank you. Any other thoughts, or you can ask a question from your perspective. You want to hear if any board members can answer your questions as well.
Because remember, for us, the educational component is obviously very important, but the social component of this organization is actually the most important one. And we here sort of feel like we one team, we work very closely with one another, and we share everything we do together, and we would like you to become part of that team. And remember, it's also an opportunity for you to connect. I mean, of course, virtually it's a bit difficult, but hopefully things will change and will become live. So it's an opportunity for you to connect with all the Ontario pathologists and probably present yourself or find a job or something like that. Right, Russ? I think you may be relating to that because you've been with the organization for so many years.
Sure. Yes, I couldn't agree more. I think it's really an excellent opportunity to network for all of us, but certainly for young people coming into the profession, just to get a sense of what sorts of positions are being recruited, what you can do with respect to aligning your training to be eligible for those positions, just to meet and speak with people and see whether that's a good personal fit, understand a little bit about where people are practicing and what's the scope of practice at that particular hospital. So it's a really great opportunity to to network just as much as the educational presentations are a benefit of the OAP.
Like if you have any particular detailed questions, like just like Russell said, for the job perspective, for the educational perspective, and more important, actually what we want is the social part of the connection with all the residents. And for example, you should consider come to different hospitals for rotation. Maybe that's one of the hospitals, finally you spend 1 month and you decide you want to stay in that hospital. That can be one of the options. And our doors are always open to all the residents.
Yes, sorry if I could ask a question.
Go ahead.
One of the residents from Western. I'm kind of further along in my training where I'm kind of potentially looking at sort of job prospects a couple years down the road. I'm not sure if this has been discussed earlier. I may have sort of missed it, but is there any suggestions in terms of where to look for those job availabilities and openings and things of that nature? And or also any advice for like booking electives? Like, is there a specific time frame, like how many months ahead of time, and who do we talk to? Those type of things. I'm sorry this has been sort of asked earlier and someone already answered, but.
No, nobody's asked that question, and I think again the OAP is an excellent resource for jobs that are being advertised. One thing that's worth doing is joining as a resident member. Heather, I think it's still free, and if you join, then you see those advertisements coming in your email box. It can give you sort of a bit of a finger on the pulse of what sorts of positions are being advertised and how to best align your training. I think in the end, you want to mix your job choice not only with the type of work, but with the lifestyle that you want to live, the place where you want to work, the group that you're working with. And so those are really all benefits of attending the meetings and meeting pathologists that are in practice in Ontario, and through networking, having an idea of where you'd like to go, and potentially speaking to medical directors like myself or others and asking what is envisioned as future recruitments in that particular practice group, what are the timelines, and so on.
That's great. Thank you so much for that answer. And I just want to sort of get some perspective. Do you think the sort of employment kind of status in Ontario, do you consider it to be sort of tight or loose, or like, I don't know, like things change over time, but what do you feel is the sort of the state of things right currently? And just because I'm thinking, if I'm going to be potentially working in Ontario, a couple years down the road, or should I be considering going elsewhere if there's sort of lack of job opportunities potentially? So.
Well, that's a complex question. I think the amount of work, all of my colleagues would agree, is going nowhere but up, which would presume that we need more people to do that work. Not only is the volume of work going up, but as you've probably experienced in your training, the complexity of the reporting. I think about when we reported cancer specimens when I first started practice, it might have been a page long, and now they run 10 or 11 pages in some cases. So the amount of information is just has exploded, and that doesn't happen without additional work involved in studying slides and things like biomarker testing and so on. So I think the work is expanding. One of the challenges, of course, is funding for positions. But we heard, if you attended the first day of the conference, the OAP conference, we heard from Dr. Tron that there is a strong push from the OMA section of laboratory medicine to recognize the explosion of work that's happening in pathology, and to advocate strongly for additional funding for more positions through the existing framework, and then looking forward through an alternative funding program. So I think in principle the outlook looks very good. with the caveat that there are maybe some limitations in provincial funding. I'm doing all the talking. Maybe Corwin or Anna have or Nancy have got some insights on that.
Yeah, or Andrea also from another region. She can talk
Yes,
what's
great.
happening in Kingston.
Yeah, I mean, I would agree in general with Russ that I think the future still looks bright in terms of job prospects. You know, and every few years, you know, this fluctuates, and anybody who's been around pathology for a long time remembers, you know, certain pronouncements of doom and gloom that never came to fruition. And really, for as long as, you know, I've been practicing in Ontario, there are opportunities available, and they may vary from region to region. But I mean, to give you an example, right now we're looking for 2 full-time pathologists in my network. And yeah, I just encourage residents to, you know, keep an eye on the market, keep an eye on opportunities. And really, your best interview is a good elective or a good rotation in your home institution. So I always encourage people to treat these rotations as an extended interview.
Thank you, Colin. Actually, it's the same as at Halton Healthcare. We are in Oakville. We take residents from different universities for elective. So by then, because we know the residents and the resident will know us. And also it's kind of a very useful tip for all the residents is that when you are, especially for the residents from the AP program, during your training, especially in the final year, particularly after exam, if you have 1 month free, go for the blood smears. To do some electives, like 3 or 4 weeks of blood smears, will really help you to find a job in the community hospital setting.
Yeah, I mean, I could say I'm looking at the OAP website right now, and there's 4 different postings currently. So I know it's always stressful at the end of residency to get a job, and but it seems like everyone does seem to find a position, and there are positions that just keep coming out, and sometimes they just come out at the last minute. So, you know, do what you like and keep, you know, making connections. And I would 100% agree with what Corwin said. And I think a lot of residents maybe don't realize this, but residency is essentially a 5-year job interview. So, you know, if you make a good impression, there's probably a good chance that, you know, you're going to get a position, or one of the pathologists you're working with will recommend you to another hospital. So just remember that.
Any other questions or any for clarifications? I mean, the other thing I'm thinking, probably after this session, actually, we would like to hear from you. You know, give us a feedback. Is once a year something like this is enough, or you want to have multiple sessions? And I'm also pretty sure that board members are here. We're willing, or even all the members at OAP are willing to answer your questions. You can approach us at any time. Just email. I'm pretty sure everybody here will be ready to take email questions, and we will, if one of us cannot answer, and we will work together to answer your questions.
Yeah, and all the information is on our website.
Yeah. If there's no more questions, we'll probably move to the next one, is that we have so many of them submitted for the abstract for this, a scientific abstract for this meeting. And now I will have Andrea here to take over this part for the awards.
Yeah, thank you everyone who submitted an abstract and submitted the videos as well. I mean, that was really interesting, and I feel like it worked out really well. It was really nice to like see the live abstract presentations. So So we did something a little bit different this year where all of the members were able to go on the website and vote for their top 3 abstracts. And that's how we decided on the winners. So this year, the most number of votes went to, and I'm not sure who is controlling the slides.
Yeah, we're doing third, second, first.
Okay, all right, we're gonna start with third then. Okay, so with the third highest number of votes is, if you wanted to move forward, Xiao-Shi Li, who did a presentation on monitoring cytotechnologist and cytopathologist discrepancy for non-gynae cytology, a useful method to enhance educational feedback for cytotechnologists. So congratulations and thank you very much. I think we'll be in touch. What we normally would do is to provide a free and registration for the following year's meeting, but this year, I mean, chances are the next meeting may also be virtual. So we will be sending a gift card for, I think we decided on Indigo or Amazon, something like that, to you. So we'll be in touch with that.
Thank you so much. Amazon sounds good.
Okay, so second place. We have Amy Calavini, who's the pathology assistant. It was really great to have abstracts from pathology assistants. And I found this abstract pretty interesting, the DIY virtual pathology gross rounds. And this week I actually did gross rounds virtually, a live, type of gross rounds with our residents as well. But I like the setup that you have, and I think we may copy that, and I may be in touch for some tips on how to do that properly. So congratulations, Amy.
Thanks.
Okay, and in first place, we have Kyrillos Faragala, who's our budding medical student interested in anatomical pathology. And no doubt we'll get into one of the programs somewhere. Hopefully Queens, come to Queens. He did a great presentation and review of the literature on the value of liver biopsy in anorexia nervosa. So congratulations, and you ended up with the most number of votes. And thank you to all the residents as well for submitting your abstracts in this altered format this year. I really enjoyed them.
This is excellent, and we're very happy for such a great representation. And we have such a variety of medical student, resident, pathology assistant. That's wonderful, and also geographically, it's pretty wide. Excellent. And not to say that our 2 educational members are GI pathologists interested in liver, but that's a little disclosure that nobody knows about.
We had nothing to do with this selection, so I like the selection process, how everyone can vote. So
it's a very neutral and a very open process.
No, I'm joking. I hope everybody understands that. But congratulations to all of you, and thank you for submitting your abstracts and work to OAP.
Yeah. Thank you very much for coming. I think Anna, you did you want to have more to say, or you say already enough?
Sorry?
Do you want to have a few more words before we end?
No, I think we said everything.
Okay,
and I would like just to thank everybody, board members, residents, pathology assistant, and everybody who participated in this conference for a great conference. It's success of all of us.
Yeah, so please give us feedback. And if you like this session, or if you want us to improve the quality or the time of this session, send us email, please.
Yeah, and the last word, please remember we could not survive without our sponsors. You can see them on the list. And without our supporting organization, E&M Management, Heather and Meredith did exceptional job. Thank you very much, Heather and Meredith as well. So if there are no any other questions, we'll meet with the board members hopefully in October and with all of you on other events that we'll be doing. And please follow our website, submit to our website, because for privacy reasons, if you don't submit your name, if you're not a member of the OAP, we cannot send you an email and provide you with the updates. Thank you.
Thank
Thanks
you. We
everybody
did
for
it.
joining
We
us.
did it. We did it.
Thank you, Meredith.
Yeah, we did it.
Bye, everybody.
Thank you, TK. Have a good weekend.
Bye.
Bye.
Bye.